trying to understand how to improve the potential of benefit of hematopoietic cell transplantation for the brain. And we have developed this long-term goal along two different paths. The first one applies directly to lysosomal disorders because it's based on the possibility to increase the therapeutic gene dosage into the stem cells to be transplanted and their progeny by means of gene transfer. So basically the idea is to take autologous hematopoietic stem cells from the patients, transduce them efficiently with late generation viral vectors like lentiviral vectors in order to render them able to produce above normal quantities of therapeutic proteins, and this would become particularly important in the case of lysosomal enzymes because the amount of enzymes that these cells could produce and secrete once engrafted into the nervous system would be greater than normal and contribute to a faster therapeutic benefit. The other possibility, which could be more broadly applied, is the possibility to foster and enhance the process of myeloid cell infiltration into the brain and microglia reconstitution that obviously would work independently from the kind of protein you are correcting and expressing. Obviously, there's a lot of discussion about the possibility to obtain indeed reconstitution of bona fide microglia cells in the brain through hematopoietic stem cells. There's a lot of debate on this area, and I think that if we want to move forward this kind of long-term goal, we need to understand more and more how this phenomenon occurs, and this is what we have done. I will show you later some of the results, but the early results that we got a few years ago basically indicated that in order to make this phenomenon happen, both in mice and in humans, what we need to do is to prepare in a more appropriate condition the brain for receiving the stem cells to be transplanted. And this means that we have to think to the brain as we think about the bone marrow. So if we want to change part of its content and so renew part of the cells that constitute it, like the microglia population, we need to create some space for the upcoming new cells. So we need to condition not only the bone marrow of the patient in order to exert myeloablation, so eliminate the resident stem cells, but we need to apply a conditioning also to the patient's brain and eliminate at least part of the progenitors of microglia that are resident in the nervous tissue. And based on this data, we have built our translational work focusing on the use of appropriate conditioning regimens for the patient's treatment. With these two main concepts in our mind, enzyme overexpression into stem cells that their progeny and proper conditioning of the patients at the time of transplant, we have started a few years ago, in 2010, a clinical trial of hematopoietic stem cell gene therapy for the treatment of metachromatic leukodystrophy. I don't really think we need to go into the detail of this disease. I just remind you that we are talking about a lysosomal disorder due to the defect in erythropoiesis A activity that accumulates sulfatides and leads to progressive and severe demyelination affecting both central and peripheral nervous system. As I told you, we applied to this disease upon preclinical demonstration, proof of concept studies, and safety studies. We applied an approach based on the transplantation of patients' hematopoietic stem cells transduced with lentiviral vectors encoding the defective lysosomal enzyme, and these cells were transplanted into the patients upon administration of a conditioning regimen that, as I told you, does not only work in the bone marrow in order to allow the transplant per se to work, but also on the brain of the patients. This is a treatment plan which is very similar to the one you are very confident with about the ALD gene therapy conducted here and in other sites by Florian and the colleagues. So it is based on the collection of hematopoietic stem cells from the patients by harvest from the bone marrow. The cells undergo correction and transduction with lentiviral vectors, and during this cell manipulation process, the patient receives his conditioning regimen. Differently from the ALD clinical trial in which the cells are infused upon freezing and thawing, so preservation and characterization, in this trial we decided to infuse the cells right back to the patients after the conditioning without any characterization, but without losing precious time, because as you know, MLD is, at least in the early onset variants, very rapidly progressing, and so in our idea, timing was a critical issue for providing the maximal chance of benefit to the patients. Up to now, we have treated a total of 21 patients, 20 of which were part of the official clinical trial that is now close to additional patient recruitment and is undergoing a process directed towards registration, marketing registration, plus a patient who was treated under compassionate use. The patients were equally divided among the two most severe variants of MLD, which are late infantile disease and early juvenile disease. And according to the inclusion criteria, these patients were enrolled and treated in a very early phase of their disease. In particular, in order to provide to the patients the maximal chance of benefit, the late infantile patients were enrolled and treated only in pre-symptomatic phase, whereas the early juvenile had to be in a very early stage of their disease in order to be eligible to the trial. All of the patients are alive. Most of them are very well in terms of neurological conditions, as you will see in a short while. We have not reported adverse events related to the treatment in any of the patients, and all of them experience a good recovery of their hematologic and immunologic functions, and obviously experience some of the standard adverse events related to the use of busulfan, so related to the chemotherapy. In these patients, the transplant worked well in terms of engraftment of the corrected cells. This is a percentage that indicates how many of the hematopoietic progenitors present in the marrow of the patients after the transplant are bearing the vector, so are genetically corrected. And as you can see, we have a quite wide range between 20 and 90%, which has an average value that falls above 50%. So the results is really good, and I would say above the standard reported thus far in the field. This sustained engraftment of the corrected cells led to expression of the therapeutic enzyme, and as per our intent, the expression was in the majority of the patients above the normal range from reference population. And this is true, for example, in CD15 positive cells that are circulating monocytes, so myeloid cells that somehow resemble the myeloid cells entering the brain and entering the peripheral nerves. There's a good correlation between the enzymatic activity in peripheral blood cells and the presence of the lentiviral vector in the hematopoietic system, and most importantly, the expression of the therapeutic enzyme in hematopoietic cells is paralleled by the presence of ARSA activity also in the brain of the patients, from which we sampled the cerebrospinal fluid, and as you can see in their cerebrospinal fluid, we could see a nice raise in enzymatic activity from 6 to 12 months after the transplant. From this time point on, we can clearly see establishment of normal or above normal enzyme activity in the patient CSF that was empty and devoid of any activity before transplant, thus demonstrating that indeed hematopoietic cells are vehicles that can deliver therapeutic proteins to the brain of human beings. And what is also interesting, and I will come back to this later on, is that we don't have a clear correlation between the enzymatic activity that we measure in the brain and the engraftment of the corrected cells in the bone marrow, suggesting something that we have also learned from preclinical models, that is a concept that engraftment of the corrected cells in the brain is a phenomenon somehow independent from what happens in the bone marrow. Importantly, enzyme delivery to the brain was associated to an obvious prevention of the typical demyelination that affects late infantile and early juvenile MLD. I'm showing you some examples, mostly focusing on early onset patients, late infantile and a few early juvenile. This is a typical MRI result from a late infantile patient in advanced stage of the disease, where you can clearly, better than me, describe the demyelination with tigroid pattern and some atrophy that affect the brain. And here you have the sibling of this patient who underwent gene therapy when she was 16 months old at the same chronological age when this picture was taken. And you can clearly see the difference. We obtain a significant and substantial prevention of the disease-associated MR markers of the disease. And this is true not only for that specific patient, which is patient number 6, but for the majority of the patients in which we have a sufficient post-treatment follow-up to look at this graph. In all of them, a scoring system that quantifies the degree of damage in their MRIs clearly indicates prevention of the damage that we can instead quantify with a high score in the control population that are untreated late infantile and early juvenile patients, among which we can identify also some of the siblings of the gene therapy treated patients. Importantly, besides preventing demyelination in these subjects, we could also observe some attempts to remyelinate. And these remyelination attempts can be, for example, seen by comparing the scan obtained at 40 months in patient 2 with the scan obtained at 60 months in the same patients. And as you can see, these areas of demyelination have somehow shrinkled as a longer-term follow-up, indicating that some attempts to remyelinate lesion could occur in the brain that has been detoxified by the treatment. As I told you, MLD is also affecting the peripheral nervous system, so what we are used to do in these children is to take little biopsy from the skin and evaluate the dermal fibers that are mostly beta fibers, and they are myelinated and can tell us something about myelin in the peripheral nervous system. And as you can see here, in these biopsies, comparing the baseline with the plus 2 year post-treatment follow-up, we can clearly see some signs of amelioration, both in terms of reduction of the storage present into the Schwann cells, for example, but also in terms of extent of remyelination, or at least presence of myelinated fibers with good appearance of thick myelin in the post-treatment follow-up, which were rarely found in the pre-treatment observation of the children. If we look at the function of the peripheral nervous system, the situation is a little bit more complicated, mostly because we can clearly monitor in the patients a dual trend. We have for sure in this parameter which we call NCV index, and that accounts for the functioning of the peripheral nerves, some subjects that have very low score that indicates a poor function of the peripheral nervous system, a difficulty in nervous system conduction, and on the other side, some of the children who have a better function, a higher nerve conduction index, or an index that has improved over time. So this variability in the cohort is still difficult to be interpreted. We need obviously long-term follow-up and more patients, but the only attempt of correlation and of interpretation that we could make was trying to compare the variation of this parameter over time with the engraftment of the corrected cells in the marrow of these patients. And the correlation turned to be positive, indicating that the more the patients are bearing a high content of gene-corrected cells in their bone marrow, the better would be their outcome in terms of functioning of the peripheral nervous system. And this because probably what delivers the therapeutic enzyme to the peripheral nerves is a direct progeny of the bone marrow cells, are monocytes that infiltrate the nerves as endoneural macrophages and that deliver the enzyme and rescue the peripheral neuropathy, which is quite different from what I told you about the central nervous system. These functional and imaging changes were correlated with the clinical outcome in the children. We are used to look at the clinical function of MLD children in terms of motor function using this scoring system, which is called gross motor function measure. And this is a scoring that follows the children through their motor development since they are very young up to they reach 5 years old, when they reach basically 100% of the score. So they acquire the ability to perform all of the exercises that are part of this scoring system. This in black is the score that we design in the context of an observational study in healthy children. This will tell you what is a normal development through this scoring system. Here in gray, you have the natural history patients that were not treated and some of the siblings of the gene therapy treated patients. And here you have the gene therapy treated cohort, the majority of which follows the normal development curve. So this tells you that the majority of the children who received gene therapy had a normal motor development following the treatment. All of them, they were treated when pre-symptomatic, so basically they were already on the line and the treatment allowed them to remain on the line instead of reaching the stage of their untreated siblings. Some of these children, in particular these three, as you can see, have a very different course. In particular, patient 4 had a dramatically different course post-treatment and basically reached the same level of disability of age-matched untreated controls. The reason for this difference can be attributed to, I would say, to one major factor. This patient, she had been treated when she was clearly symptomatic. She was in an acute phase of her disease. She was an early juvenile patient. She was enrolled when mildly symptomatic, but between enrollment and actual discharge from the bone marrow transplant unit, she experienced this extent of deterioration. So basically the treatment had not the time to halt her disease. These two other children who had been in a, I would say, relatively benign course, but had not reached the best of their ability because they still need, for example, aid for walking, they were treated when very mildly symptomatic, late infantile patient who did not already manifest motor regression at the time of treatment, that they were experiencing a sort of delay in new motor acquisition. And indeed, after the treatment, they did not acquire any new motor milestone and stabilized their disease. For as far as cognitive performance is concerned, we have a very similar result. In particular, for I would say the majority, the large majority of the patients, the cognitive and verbal performance before and after the treatment had remained within the normal references for their age, so they have a normal IQ. The patient who has the lowest score and that fell down below the level of measurement by this kind of instrument is again patient 4, who experienced the major drop in her verbal and cognitive performance at the time of transplantation and engraftment achievement. So this experience, which is obviously still ongoing and on which a lot of data are still missing, has told us anyhow that hematopoietic stem cell gene therapy is a feasible treatment. It can be safely administered, it can be tolerated, and it can allow to establish a very high engraftment of the gene-corrected cells at unprecedented levels in the hematopoietic system of the patients. I think it has also told us that this means of treatment allows not only for enzyme delivery to the peripheral nervous system, but also to the central nervous system up to normal or above normal levels, and this is associated to the evidence of a clear therapeutic benefit in early onset patients when they are treated at a pre-symptomatic stage. For the symptomatic patients, obviously I've shown you some preliminary results. We have many more patients that have been treated more recently in a symptomatic stage, and for sure their long-term follow-up will tell us something more about our current limitations. So how can we extend the experience and further implement it in order to maximize the benefit for the patients? For sure, according to what we have right now in hands for clinical applicability, first of all, we need to critically identify the patients that should undergo treatment administration, and this could apply to this particular setting, so metachromatic leukodystrophy, but in general to this kind of approaches applied to neurometabolic diseases, so identifying the patients who may better experience a positive treatment outcome according to their disease at the time of treatment indication. Guarantee an adequate exposure to the conditioning regimen that, as we will also see in a short while in mice, is critical indeed to achieve a sustained enzyme delivery to the brain, and implement, in the case we are working on hematopoietic stem cell gene therapy, a high transduction rate of hematopoietic stem cells in order to guarantee the best potential for the corrected cells to make their job. But for sure we need to do something more, which is increasing the potential of this therapeutic approach for patients who are already symptomatic, and this means that we need to make this treatment working much faster than it is right now. You have seen a kinetics of enzyme delivery to the brain that clearly reminds to the experience also in allogeneic stem cell transplantation. We have always been told that it takes at least 12 months to achieve sustained enzyme delivery to the brain. That is something similar to what we are seeing. We need to make it faster. And how can we make it faster? We clearly need to understand more and more about how this process occurs. We need to implement innovative transplant protocols that would favor a rapid turnover of microglia, and we may further improve also CNS conditioning regimens. And I will try to show you some of the ideas that we have in order to implement indeed these goals. These ideas mostly come from animal models, where we could initially clearly demonstrate that the mechanism we rely on in the patients for therapeutic efficacy indeed occurs, and occurs in a sustained manner in the mice. In particular, in the mice, you can clearly follow this phenomenon of microglia turnover by transplanting genetically labeled stem cells that will express a green marker into the conditioned recipient mice, and following them and their progeny into the brain, where you can find clearly, upon appropriate experimental condition, a wide progeny of the transplanted hematopoietic stem cells expressing GFP and showing microglia-like features. So we have tried to understand how this could happen, and we have clearly demonstrated that this happens because the conditioning regimen that I told you before is fundamental in order to kill the progenitors of the mature microglia that are present in the patients and in the mice brain. And this killing that you can monitor, for example, by annexing staining, is clearly associated to the use of some conditioning regimens, being the best one thus far tested, busulfan, and leads to the long-term depletion of mature microglia and senescence of the same population, with a nice correlation between the extent of killing and the extent of reconstitution in the long term of these populations by the transplanted cell progeny. We have also understood that the mechanism by which, once we create space in the brain, microglia is reconstituted is based on the possibility that a fraction of the transplanted hematopoietic progenitors migrates short-term into the brain, independently from the administration of a conditioning regimen and from the presence of a disease state. If the conditioning was there and it was the right one, then this fraction of the early progenitors that has home to the brain will have the chance to engraft and to expand and to reconstitute mature microglia. And indeed, if you monitor the brain of mice transplanted in a very complicated setting of sequential transplantation, being, for example, red cells in the periphery and green cells in the brain, you would see that indeed microglia in the brain is made only by the centrally home cells, not from the bone marrow periphery, and that is based on the proliferation of these CNS resident cells. So based on this finding, what we thought is that instead of relying on migration of cells administered IV into the brain, we could directly transplant the hematopoietic stem cells into the brain, and in particular into the cerebroventricular space. And this is what we did, always in the simple mouse model I've shown you before, and we obtained indeed a very positive finding, because we could see that upon injection of the stem cells into the cerebroventricular space, we could reconstitute widely microglia populations in the mice, and this occurred with a kinetic that is much, much faster than the one we are used to see by IV transplantation. So our data suggests that whatever the conditioning regimen we use, if you transplant hematopoietic stem cells ICV, you will make it faster. That is indeed what we were looking for, to fastening enzyme delivery to the brain or protein delivery to the brain and microglia cell reconstitution. So what would be the next goal that we will try to accomplish, possibly in the Boston area, is indeed to exploit this concept of autologous or allogeneic stem cell transplantation into the cerebroventricular space in order to implement more efficacious transplant protocols for leukodystrophies and neurometabolic disorders. Indeed, this phenomenon is under deep study. It resulted to be extremely reproducible with different subpopulations within the stem cell compartment. It is reproducible using human or murine stem cells. It is flexible. We are right now testing different protocols in order to achieve in a different timing and kinetics microglia reconstitution and hematopoietic system reconstitutions, and we are building biodistribution studies that will indeed lead the clinical translation of this approach. The other long-term goal we have is to indeed achieve selective killing of microglia progenitors in the brain, trying to spare from toxicity the hematopoietic system, so the bone marrow of the patients, and these are some of the ideas that we are moving forwards for clinical translation. So the conclusion is that for sure we have obtained in mice, but most importantly in patients, proof of concept that hematopoietic stem cells can indeed provide a real therapeutic benefit to the brain of leukodystrophy patients. But we have also some new ideas, some new data coming from the murine models that could drive novel applications of this kind of approach into other lysosomal disorders, possibly also adrenoleukodystrophy patients and neurodegenerative diseases in general in the long run. And this was done, most of this work was done in Milano. I'm losing the most important slide, which is that one of the acknowledgement. Obviously, the clinical trial has a number of key participants, both in the preclinical part, in the laboratories, and in the clinical setting. It's a clinical trial that was originally funded by a charity, that is the Italian Telethon Foundation, and is now sponsored by GlaxoSmithKline, which is, as I told you before, no, it doesn't work, which is working with a lot of effort and strength towards the marketing registration of the drug. And as Florian told you, the new part, the novel insights and the novel development of the ACV transplantation will instead be developed clinically here in Boston, along with my move here at Children's Hospital and Dana-Farber.
Like at a rock concert, you get too close.
Yeah, I think so.
So great stuff. So I really look forward to working more intensively. I think a lot of the themes our lab is also thinking about, and so it would be great. So one quick question before Sanjay jumps in. So ICV, right? Very exciting. Are you envisioning that this would be adjunct to IV administration? Because I'm still thinking in metachromatic leukodystrophy, at least you're also thinking about the peripheral nerve, and how does the ICV affect DRG or peripheral nerve? And I'd love to hear whether engraftment differs between brain and peripheral nerve, and what you think about that.
So the easiest and faster answer would be it depends on the disease. So if you think about a disorder that is mostly, if not exclusively, affecting the brain, the long-term goal would be to spare toxicity, risk related to vector integration or whatever for the bone marrow, and just concentrate on the brain for route of cell administration and conditioning. But this is obviously a very long-term goal. The easiest approach would be to co-administer ICV and IV cells. That could be both transduced or one transduced and the other not, according again to the disease you are targeting. And obviously the timing of the two administration may differ, and we are trying to mimic this in mice in order to understand who could contribute to which extent better to CNS turnover or PNS turnover according to the timing of administration. What is interesting is that the brain can communicate to the marrow. So if you transplant in the brain, fraction of the mice will have some bone marrow engraftment, because there are niches in different tissues that do communicate. And the niches are not only hematopoietic, but for example, my view is that the hematopoietic stem cell niche or microglia progenitor niche in the brain is very close to the neural niche. So there's a complexity also of signaling that would allow some more flexibility than what we think is the simplest interpretation we have right now.
But you don't see spillage from ICV into systemic circulation or DRG correction that is now transferring benefit to
you see some reconstitution in the spinal cord upon ICV transplantation, microglia reconstitution in the spinal cord, and then if you have a secreted enzyme, this could contribute to spreading. It depends on your protein also, not only of your cells.
Sure. Okay, Sanjay. You have a microphone? Another? Okay.
So I think something. Am I live? Hello? Okay. So there's actually a drug that can induce depletion of microglia fairly specifically within, I think, several days or maybe a week or two of treatment. It's made by Plexicon. It's a FLT3 inhibitor called PLX3397. And pretty much within a week or two of treatment, you can deplete all of the microglia in the brain, which may open up niches for this kind of treatment.
You know, it's we are trying to get it, but for example, we exploited also the CD11BTK mouse, which is similar. I mean, you can provide ganciclovir and ablate all of the myeloid cells, and if you had transplanted the mouse previously with healthy bone marrow cells, you would just deplete the microglia in the brain. But if you do that, if you just kill the mature cells, you don't reconstitute microglia again with the transplanted cells. You just have an influx of macrophages taking their place. What you need to kill are the progenitors, not the mature cells, like you do with bone marrow transplantation. If you just take out red blood cells, white blood cells, you won't achieve engraftment. You need to deplete the progenitors.
Right. But if you did both, you might actually get an acceleration of the process instead of the normal turnover.
But I think it's very difficult to find something that kills both. We would like to try Plexicon to see whether it could kill progenitors. We have not yet achieved the proof because we are waiting to get the drug, but it's not easy. It should be very powerful to kill both. But I would love to try, absolutely.
Or you might need two different therapeutics to kill both.
You know what we need? It's something that we are trying to do intensively. We need to understand what are the features and who are these progenitors, because we don't have a marker. So that's the difficult part. We just know that you can kill them with some drugs, but you still need to identify markers.
My question was comparable and related to the optimal conditioning for ICV administration of the cell population. I would expect that bisulfan, the way that it was used in the rodent, may not be optimally contribute there. Can you, so while you've just discussed the benefit of other conditioning regimens, the rodent experiment I understood you used bisulfan to deplete. Have you done that in the absence? Which means I could imagine that it's such a unique compartment when you go in ICV that there could be other benefits of the transplanted population there.
The point is that if you transplant wherever is the route, IV or ICV, and you don't make space, you may have a little engraftment of the cells you have transplanted. They will stay there, but will not expand. So the point is that they can find a little niche, say there like 0.1% of the total brain populations, and not expand. So you need to make space if you want to expand, either at the time of transplant or later on.
Very nice talk. The question is that there are present studies that are...
Wait a second. We need volume.
Yes. Okay. I'm Asif Parker, and it's a very nice talk. Thank you. I have a question about ongoing... there are other studies in other metabolic diseases, including one that Bluebird is conducting, is we're selecting CD34 cells, which are primarily the stem cells, not the progenitor cells. Based on your talk, how would you comment the engraftment of stem cells related progenies or other, and not selecting the progenitor cells?
CD34 is a wide and broad population which contains progenitors, stem cells, more committed cells, so it's a wide and broad definition. If you want to go closer to stem and progenitors, you start adding 38, and you take the 38 negative, 34 positive cells, and still there you have microglia progenitors. And you can go even closer to the stem cells with additional markers like SLAM receptors. And the closer you get to the stems, the closer you get to microglia progenitors.
Thank you.
So Alessandra, so now that you're moving from IV to ICV, it begs the question: how you're using ex vivo lentiviral transfected cells. How does this compare to AV correction that is going either intracerebrally? And have you compared notes with Patrick? What are your thoughts in general? We do AV intrathecally and ICV, and we also hit microglia. What is your thinking on the approaches? Clearly are different, and what both cases the idea is to get faster to the cell that needs to be corrected, but are we
What's the fastest one?
Yes.
That's the main question.
You fast is good, but maybe sustained is also good, and as you said, there might be different populations.
I think so. We have done, in collaboration with Angela Gritti, a lot of murine work doing stem cells, IV standard transplantation, plus intra-brain, intraparenchymal. She's mostly doing lenti injection that would be similar to AAV. And for sure, you can get some results. Like in the GLD model, you have a benefit, an added benefit. We will do some comparison of that approach. So vector in the brain plus stem cells to our new approach, so ICV transplant, to get some kinetics and ideas. But in general, I think the advantage of this approach is a widespread distribution that is not easy to be achieved by direct delivery of the vector in the brain. Whenever you do multiple injection sites, and even if you prefer AAV, that will travel a little bit along the nerve fibers instead of lenti, but in any case, the widespread distribution that we achieve by microglia, that as you've seen in that picture, they go all over the brain, could be an advantage in the long run.
Sure, yep. So I guess direct injection into the brain is, again, a little different than some of the approaches with Brian Caspar going intrathecally. And so I think he does see more widespread distribution. But then you really need to have proteins that are secreted and actively transported, otherwise you stick on the ventricular layer. Okay. So we should compare notes, because I think we might think slightly differently about that. But I think that some experimental work could have addressed these issues. Yeah. Great. More questions? Yeah.
So I didn't see MPS 3A or Sanfilippo in your slide. In your last slide, it was not there. What do you think about that in this disease where transplant doesn't work very well, and there are some thoughts that probably we need an overexpression of enzyme as it is for MLD. So I want to hear your thoughts about these. So I think you can take some easy targets and some more difficult targets. The easy target, for example, is MPS 1, where you know that transplant is already doing good and you can simply improve. The difficult targets are like MLD was, MPS 3A or 3B, that you know transplant is not particularly beneficial for, but you can improve through enzyme overexpression. So you can choose whatever you wish, the easy or the most difficult route. But I think they are both worth pursuing.
Great, thanks. Another round of applause for Alessandra.